One of the other chronic responses to exercise is we have an increase in our blood volume and our hemoglobin. And this allows greater filling of that left ventricle. And if you recall, we had a greater chamber size, and now we have a greater volume of blood to fill that left ventricle. And so that also is going to increase our cardiac output. And it also aids us in the lungs, because if we have a greater volume of blood, more of the blood will fill up into the capillaries that surround the alveoli to a greater level, to a greater depth, so there's more contact with blood with the alveoli and greater oxygen exchange. And with the increase in our plasma volume usually occurs fairly quickly, whereas our red blood cell count increases, but it takes a little bit longer. And so these chronic adaptations are more away from the muscle. And so now we're going to look at adaptations that occur in the muscle. So when we talk about adaptations that occur at the heart, we call that the cardiac level or centrally. When we talk about adaptations that occur in the muscle tissue, that's peripheral adaptations. And so some of the changes that we see are they increase the oxidative energy production capacity of the muscles. So the ability to produce ATP using the oxidative system in the presence of oxygen. And we see increase a number of capillaries in trained muscle. So there's a greater ability to deliver oxygen-rich blood to the working muscle. And we'll see what we call an increased capillary to fiber ratio. When we aerobically or endurance train, we don't see great improvements in the size of the muscle fiber, but we see increased capillaries. So this is going to increase the ratio of the number of capillaries that are available to the muscle fiber to deliver more oxygen to the muscle fiber. We also see their greater diameter. So there again, increased ability to bring oxygen-rich blood to the working muscle. And with the increased blood volume, it allows us to deliver more blood. The oxygen is delivered quicker to the mitochondria, and the mitochondria is where our acetyl-CoA, and we go through the Krebs cycle and the electron transport chain to produce ATP oxidatively. Muscle fiber change, this is one of those kind of questionable things. We do see, though, for some muscle fibers, we do see an increased oxidative capacity within even the type 2A muscle fibers. But as far as being able to change them over to from type 2 to type 1, that is up to debate. We see an increased number of mitochondria, so that just increases the number of sites for energy production to occur. We see more oxidative enzymes, so we're going to, those allow us to speed up oxidative or aerobic energy production. Myoglobin is what transports the oxygen from the through the cell into the mitochondria. So that increases our ability to get oxygen to the mitochondria for energy production. And there again, we don't see the hypertrophied or the increased muscle size, but primarily what we see for our adaptation with aerobic training for running or biking, something sustained and sustained intensity, is that we see this great peripheral adaptation where the muscle's so much more efficient at producing energy. And this is just a slide that shows a muscle. And so, this is a slide that you would not be expected to be able to pick up and identify these parts, but you might see some of the terms that we've used, such as the mitochondria, where the oxidative energy production occurs. The muscle fiber, you can see the striation in the muscle fiber from the sarcomeres. And if you recall, the connective tissue that surrounds different parts of the muscle, the perimysium and the endomysium, bundling of the muscle fibers is the muscle fascicle. So those are just some review terms. Also within the aerobically trained muscle, we see increased stores of glycogen, so we have more glucose that can be available for energy production, as well as increased stores of triglycerides, which can then be broken down into free fatty acids for oxidative energy production. And so we also see, as an aerobically trained individual, they have a greater capacity to fuel their exercise using this unlimited supply of fat in the form of free fatty acids for energy, where they rely more on free fatty acids for energy production rather than glycogen. And that's very positive because glycogen is limited stores available to us. And so the body will shift to using for free fatty acids, and you'll see that with Olympically trained athletes, where they're able to fuel exercise using fat and spare their glycogen so that they never fully deplete their glycogen, and towards the end of the race they still have glycogen available to allow them to maintain higher intensity running. And so we see this strong ability to produce energy oxidatively, and we're less reliant on the short-lived anaerobic system. We've mentioned this before, the increased AVO2 difference, and a chronically trained muscle is so much more efficient at taking oxygen. It can use that oxygen, so it's going to extract more oxygen. It has the myoglobin available to transport it. It has the mitochondria available to produce ATP. It has the enzymes, also increased enzymes available for energy production. So all of that just encourages our muscles' ability to use oxygen. And this is really important for people who are compromised, like centrally, if they've had a heart attack and they can't really increase the strength of their heart's contraction to greatly increase their cardiac output. If we train them peripherally, that they can produce more energy oxidatively, increase the oxidative capacity in their muscle, they can often return to normal activities just by training the peripheral muscles, even if they're compromised centrally. And so this is one of the main points to cardiac and pulmonary rehabilitation, is even when somebody has compromised lungs or cardiac system, if we train the muscles, they many times can return to normal activities. So here again, just restating that the oxidative capacity of the muscle is much greater. And other adaptations we see is with aerobic training. We see in changes in the blood cholesterol, and cholesterol is related to heart disease. And we see an increase in HDL cholesterol. And we see a decrease in triglycerides and LDLs, which are types of blood fats that are more related to heart disease. But HDLs are what are considered the protective type of cholesterol. They bind with the low-density lipoproteins, or the LDL, and they transport it to the liver. It's the LDL cholesterol that deposits in the lining of the artery and forms the hardened plaque that blocks the artery. As far as respiratory adaptations go, the respiratory system is usually not the limiting factor to exercise. We see that with submaximal workloads, usually the respiratory rate is decreased, and that's because they have a greater tidal volume. At maximal workloads, a much greater increase ability to increase their ventilation because they can increase their respiratory rate and their tidal volume. And one of the significant differences as well with aerobic training is if the breathing muscles, those external intercostal muscles that expand the rib cage, those muscles are more trained that they will not use as much oxygen, and then it makes more of that oxygen available to go to the working muscles, produce more ATP, so the trained athlete can achieve higher levels of work without having to go to anaerobic energy production. And I think I mentioned here before the increased pulmonary blood flow allows us to have greater diffusion of oxygen into the blood. And so this just shows the alveoli and the capillaries that surround the alveoli. When we have a greater blood volume, we have more blood and capillary area available for oxygen exchange. So the VO2 is, our VO2 max is increased usually with aerobic training, and this is one of the most significant differences that we see in trained individuals. And primarily the ability to consume more oxygen, which is our VO2 max, is due to our increased ability to send more oxygen via cardiac output to the working muscles. We have increased red blood cells to carry oxygen. We extract more oxygen at the muscles, increasing our AVO2 difference. We have greater delivery of oxygen into the muscle bed because we have more capillaries. And so all of this allows us, it's not just we're able to send more oxygen, we're able to extract more oxygen, but also at the muscle we're able to use more oxygen to form more ATP. And so that's why an individual can reach higher levels of work, consuming more oxygen to fuel that work. And this is just, I've shown you pictures before about how VO2 max is measured with a mouthpiece, and then just measuring how much oxygen they breathe in and then how much they exhale as well. And so other differences we'll see is with aerobic training, an increase in the anaerobic or lactate threshold. That's where we start to significantly accumulate lactate. And primarily the ability to increase lactate means that an athlete can work harder at higher intensities and still maintain producing energy oxidatively without shifting into the more short-lived anaerobic system. But for us to be able to increase our lactate threshold, individuals usually have to be working at higher intensities. You can't just go out and run a steady state, easy run every 3 times a week and bump up your lactate threshold. You have to be exercising close to that lactate threshold at high intensities, and that's what will push up the lactate threshold so you can maintain aerobic energy production longer. These are just some words. AVO2 difference, pulmonary diffusion is where we have gas exchange. Lung ventilation is the taking air into our lungs. Tidal volume is the depth of our respirations. Respiratory frequency is how quickly we breathe, how fast we take our breaths. And VO2 max is just our ability to consume the maximal amount of oxygen that our body can consume and use. And then lactate threshold is where we start to accumulate lactate. We can't metabolize it to get rid of it, and it starts to accumulate. And once that happens, then we're moving more into anaerobic energy production, and there's going to be a cessation of exercise.